Hi friends, it's Kim Skorupski here at University of Texas Medical Branch in Galveston, Texas on the Faculty Factory podcast, looking at a new friend, Dr. P. Ravi Shankar. Let me tell you who is Dr. Shankar. He is a faculty in the Center of Education and a program coordinator at IMU, which is in Kuala Lumpur, Malaysia. And Dr. Shankar comes to us thanks to Dr. Paige Morahan, who is with FAIMER. FAIMER Fellows, it's the Foundation for Advancement of International Medical Education and Research. This is all going to be on the website, but Dr. Shankar is MBBS, MD, the FAIMER Fellow I mentioned. He is an assessor, a top 2% researcher, member of a global counterspace program, member of the World Association of Medical Editors, on and on and on. He's a board member, an editorial board member of many journals. And I'm just so excited to talk with him today. He has lots of interests, and I'll just let you start us off, Dr. Shankar. Take it away.
Maybe I'll start with the humanities. So I was working in Nepal. I spent several years in Nepal. So I joined for the FAIMER fellowship program. So this was at a regional institute in India. So as part of the FAIMER program, we had to do what's called a curriculum innovation project. So I was thinking about what I could do, and then I thought I have an interest in the creative arts, creative writing, traveling, and photography. So I just thought I will combine both and try and offer something on the humanities. When I started, I had very little knowledge on what the humanities are, what work has been done. And then we did quite a lot of research on different areas. So a lot of people helped me with starting the humanities because it was something totally new in Nepal. So initially, I started by offering a voluntary program. So the dean at the school where I was working, it was a private medical school. So it's in a beautiful city called Pokhara in Nepal. Initially, we had a lot of challenges getting students to sign up, and medical students are very busy. But eventually, we managed. We offered it, I think we offered about 6 or 7 sessions to the students. So we used a lot of different methodologies, like we used presentations, we used group work, we used role plays and paintings. Later, I shifted to another medical school. That was a new medical school in Kathmandu. That's the capital of Nepal. So they wanted me to offer the humanities program to all first year students. So that we started working on that. And so then we started offering it to all students. And we also had some other people joining it, some clinicians, some basic science faculty. And so that was a program in Nepal. And then I shifted to the Caribbean for some time. And so in Aruba, I offered it again. The dean was very keen that I offered it. So I offered it along with fewer colleagues, especially there was a psychologist from Canada who was associated with me for many of the programs. So again, similar methods, and students found it interesting. Sometimes they felt maybe it's not assessed in the USMLE. That was a challenge because it's very much, many students are very much USMLE focused. But eventually they understood why we are offering it and what are the benefits which come in. And maybe the 2020s, I did a lot of workshops for medical school faculty in India before COVID. So maybe some of the schools were very keen for me to offer it to both the students and faculty. So that's something I did. And since September 2020, I'm working at IMU University. So here I did connect that they had a center for bioethics and humanities. The bit right now is no longer functioning. And they also had an online art gallery, very interesting. They used to call it the Inspire Gallery, but again, with the new website, I do not see it there. So I used quite a lot of the paintings. Then we offered quite a lot of these courses to people in India. And maybe the last 3 to 4 years, I do more of cinema, use of cinema in medical education. So we offered some workshops during the conferences in India and our conference here at IMU University. And last year we did an elective for dental students on cinema, empathy and cinema. And we plan to offer that again this year.
Wow, Ravi, thank you so much for sharing that story. Could you tell us, you mentioned it was maybe a little bit of a little work explaining or trying to pitch the idea of why and the benefits. So for people who are listening to this who are saying, well, right, Dr. Shankar, exactly. Medical school is intense. The practice of medicine is even more pressure filled. What is the value of humanity? So if you could tell us, how did you purpose that? How did you make people understand the value of art and cinema and museums and galleries? And then, if you wouldn't mind telling us a little bit about the curriculum, you mentioned role plays and like, what is it that what are the objectives? What do the students learn in the curriculum?
Maybe the most important benefit or the easiest to convey would be communication skills because they do role plays, they express themselves. So communication skills could be an was maybe a good starting point for us to take it forward. And then we talked about how they can put themselves in the position of a patient. Because as students, many of them do struggle to identify with different patients. And we also told about how there have been studies where students' diagnostic skills have improved through art. So that again is something we talked to them about. Some students were, of course, more open to the idea. Some others had more reservations. But then working together with the colleagues, that helped them. And maybe once someone is more receptive, they were able to bring others on board. So
Wow.
that's what happened. So initially, I usually start with empathy. So whenever I do my module, the first one is empathy. So we look at empathy and we explore that and what are the factors in empathy. Then I think I usually go into what it means to be sick. So, especially in Nepal, what are the challenges in being sick? And it's also true for other countries, even though Aruba has health insurance. Everywhere falling sick is a challenge. So that's the second topic I go into. Then I look at the patient generally, what a patient goes through, maybe from the not from the biochemical or the biological, but from the social and those perspectives. And then we look at the patient doctor relationship, the relationship between the patient and the doctor. And we look at family. What's the role of the family? And usually we end with death and dying, because death and dying is again, usually we of medicine traditionally regarded it as a failure if someone dies. So, maybe that's still, maybe a lot of students have challenges coming to terms with death and dying. And we explore some aspects. It's a very complex phenomenon, but at least we introduce them to death and dying.
I appreciate that. You're reminding me of my colleague, Dr. Margaret Chisholm from
Yeah.
Hopkins, who does a lot of work in this space. And I remember doing during COVID, we did this on Zoom where she showed pieces of art and we were just silent and noticing what did we observe about that. And it is it seems kind of on the surface when I first thought to do it, I'm like, well, what's the point of this? I don't understand. This is kind of, isn't it obvious what's here? And then when you have people share what they observed, you say, oh, well, I didn't notice that. Or
Yeah.
there's a table there. What's the table doing there? And what does it mean? Exactly. It's not really, what purpose is it serving? And you start to notice things that other people notice, and then you get curious. So it's one of those interesting experiences where you think, well, that's just nonsense. It's a tree. It's green. There's a cloud. There's a bird. But then when you really get into it, that's where I think the connections of, oh, what is it? It's a patient who's clearly giving away symptoms that they've got, pertussis or whooping cough or something. It's obvious. Well, wait a minute. Is it? And what else is there that I'm not noticing? Or why is there a table there? And what's up with that table? And what does that mean? So that's what I really find fascinating about the work you do, Ravi, is that recognition that we're sometimes that we may be aware on certain levels of things, but our brain is working so hard to put things in boxes
Oh,
that we sometimes don't notice other things that are really important.
that's correct. Yeah, very true. Yes. Yeah. So I think, yeah, because we do quite a lot of sessions for faculty. And I would say, especially in India, there has been quite a lot of change in faculty attitudes and faculty knowledge. I would say mainly, primarily, I would say because of FAIMER. There are quite a lot of FAIMER fellows now in India, 4 FAIMER institutes. And I think there are about 16 or 20 fellows graduating each year. So a lot of people are more open to these ideas. Maybe they're not able to implement it in their institutions due to various challenges, because getting enough faculty on board is also challenging because student numbers are large in many institutions. So they need a lot of people to support them. And again, finding time in the curriculum is again an issue. But people have a more open attitude now towards a lot of things in education. So that's something I noticed maybe over the, maybe I used to go maybe in 2008 to 2012, and now when I go 2021 to 2024, there's been a change in attitude and people are more open to research and new ideas,
Mhm, mhm.
curriculum projects, and lots. So changes have happened.
Yeah,
That's what I would say.
I agree. And I'm really curious as well about the of artificial intelligence. When you started talking about the curriculum in the humanities and you said you start with empathy, and I thought, yes, the one thing that we are noticing with artificial intelligence for all of its benefits, it's hard to program empathy. I mean, you can, of course, these large language models are teaching these chatbots and whatnot to be or act as if they're empathetic, but nothing substitutes for that human experience of, oh, I hear what Robbie's saying. That sounds familiar to me on a personal human level. And I'm now noticing Robbie's body language and his eyes twitching or his hand gestures or his body positioning, all the respiration, things I can notice on a human level, to me is the fundamental component of empathy. So I love in your program that you start with that because I think that's something that makes the patient physician experience. You
Quite
can't
different. Yeah,
reproduce that with AI.
yeah, yeah. At least maybe not now. We don't know in the future, but still it will be a challenge.
I know you're a top researcher. Can you tell us a little bit more about the research you're doing and how you manage to fit it in like everybody else around the world who are struggling with seeing patients and documenting and education and administration and all the work we do?
I did some research during my postgraduate days. So luckily, I had mentors and guides who were very supportive of research. And then I started in Pokhara. So when I went there, we had to create everything. There's no research infrastructure. It was a small private medical school and just set up. Maybe it was set up about 6, 7 years ago, but research was still at an infancy. But then we did quite a lot of work on rational use of medicines. So drug utilization and teaching medical students on how to use medicines rationally. And I think there's a connection with the United States. So what happened is the United States Pharmacopoeia gave us funding to start a drug information center, so and a medication counseling center in the hospital. So once that came in, we had lots more resources. We had It came along with different computers and printers and access to different databases. So we were able to use that not only for service but also for our research. So that's something which gave a stimulus. And we eventually started publishing a drug information bulletin. So this is back in 2005, 6 or something like that. And then we started ADA reporting adverse drug reactions. And quite, these are things which are quite new in Nepal. And then eventually I started becoming more into educational research, especially once I did the FAIMER fellowship, because that gave us a lot of ideas and a lot of support and networks. And again, you could do with your junior fellows. So you could act as a mentor or a guide to them. And in Aruba, actually, we shifted the curriculum. They had a subject-based curriculum for the basic sciences. So along, I was one of the persons involved. We brought in an integrated curriculum, which is like quite common in most other countries. So an integrated organ system-based curriculum. And we brought in humanities, we brought in critical analysis of literature. And so that took some time. But again, that gave us a lot of ideas for research and along with changing the curriculum, strengthening it. And yeah, the challenge, of course, is finding time because a lot of other duties and responsibilities. I try and manage wherever I can, find time. Because here again, we're involved in faculty development also. And then we also look at student evaluations in my university. So it means I'm part of the team, someone else who does most of the heavy lifting, but then at least I look at the reports and then we do different surveys. Finding, yeah, I try and manage whenever, whatever I can. But sometimes it's a challenge. And
Yeah.
sometimes it doesn't, it gets rejected often. That also
Oh, right.
happens.
Sometimes it gets rejected? No. Oh,
No,
I feel like we're always rejected.
eventually it might get somewhere, but then rejection is the challenge always.
So yeah, that isn't that interesting that we by our work, and we're so proud of our work that we are teaching our learners that part of this work is rejection. And so the hidden curriculum is that you will be rejected a lot. As great as you are and as smart as you are and as
Yeah,
hardworking as you are, a lot of what you do will be rejected.
rejected. Yes, at least for some time. Yeah, eventually you might find somewhere. Rejection is a part of.
Yeah.
Thing. They have to get
Rejection and
used.
perseverance.
But yeah, especially when we do some work with students, sometimes we tell them not to get disheartened. Can happen. Research work, especially student research again, because students may not do at that level. They have other limitations.
Right, right.
Again, yeah, motivating them, keeping them focused is again a challenge.
Yeah, I mean, I wonder sometimes with the next generations that they look at us and think, why would what is with you people in that generation? You just sit there for years and years and years and keep submitting these papers, and they keep saying, "Why would you bother doing that?" I see like my colleagues' kids who are in their like late 20s, and sometimes I wonder if they would have the stamina to withstand the constant and repeated rejections to stick with it. So I think that's maybe a lesson that we're really good. If anything, we're good role models in academic health for leading by example, leading rejection by example, that we show how to be
Rejection is a
resilient.
part of the process. Yes.
So what's next for you, Ravi? I mean, you've done so much in different countries, and uh, where are you going next in terms of, giving presentations or doing your work, or what's in your head that you're noodling around for the next, I don't know, couple years, 3, 5 years? What are you excited about?
Yeah. No, yeah. So maybe next week, there's a conference nearby. So that's a city called Malacca. It's a historic city. So I'm going to talk about the interprofessional team. So I'm looking at it from a broader definition, not just healthcare professionals, other people. The patient is a part of the healthcare team, the sanitation workers, politicians, and people who give the resources. So that's something my talk will be mainly on that. So I'm using the humanities to bring home that point. So how we have to look at health broadly. Maybe of course people know, but I just want to emphasize that message.
Oh,
So,
are you going to start with empathy and get those politicians to be empathetic and the
yeah,
sanitation
maybe
workers to?
We have some, I have a movie clip. I think I start with a movie clip, short one, and that, shows the different aspects of the relationship. So
Oh,
there are
I love.
movies, and then I think I have some paintings, all the arts, maybe a role play. We won't do a role play, but at least they will look at a role play. So that's what I'm planning. So
I love the
there's some kind,
interactivity of it. I love
yeah.
that. Maybe we can have you come back on sometime and we could do, or you could bring some of your trainees and do a role play on the podcast so people could see how that goes.
Yeah, some of them are quite interested. We have some people collaborating with us on different research. In fact, we did one on climate change, and then they're doing something on sustainability. It's a joint effort between students and faculty. I think we're looking at the data now. In fact, we're doing the analysis. So climate change is again a big area. So at least some of it I will focus on climate change,
Mm.
planetary health. Along it fits in gels in well with the humanities again. Because all these climate change has multiple drivers. We have to look at what will happen, maybe over the next 2, 3 decades. It's quite
Yeah.
challenging.
Well, now that interesting, Ravi, that you say that now that I moved last August to Galveston, it's an island in Texas, and I'm learning more about coastal regions around the world. And with water levels and anticipated the projections that many areas of the world will be underwater in 10, 20, 30 years. And that's not saying 100, 300 years. We're talking in my lifetime, God willing. So that has tremendous implications for not only communities and society, but health naturally. So that is
Yes.
interesting. And certainly in Malaysia, where you are, I remember I spent in 13 months, I lived in the Philippine Islands when I was at
Okay, okay.
15 years old. And now, when I started thinking, there is a lot of coastal areas around the world that this has tremendous implications and for health. So I think that's going to be a really interesting conference and a great conversation you'll have.
Yes, last year we have an IMEC conference every year. That's an international medical education conference. So
Okay.
last year the theme was planetary health. So someone was talking how much it costs Malaysia due to climate change every year. So they said somewhere around 30 billion, I'm not sure, something like that, because of the consequences.
Yeah.
That's something we're working on. We do faculty development. In fact, I got a lot of interest in small group learning and PBL. When the PBL now has been around for quite some time, it's changed due to computers and immediate access to information.
Hmm.
Students just Google or
So,
search it out online. Yeah, they're not, so some of these processes have changed. But then it's quite interesting, even today,
yeah.
how because I did not have PBL when I was in medical school. So this is something which, but I would have liked it, especially we never really understood why we are learning the basic sciences. So some of it, so much of the basic sciences and so much of information. And the application came much later when you
Yeah.
went to the clinics. Yeah.
So it's interesting also that you mentioned problem-based learning, PBL. I'm wondering when you just said something about curriculum development and learners these days who just Google things and they quickly can ask Chat GPT to come up with something, and all these apps. You wonder, like, will we really need organic chemistry? Like I remember someone said to me, why does organic chemistry have to be the stopgap between getting into completing medical school or not? Like, why that there's certain, I'll say in air quotes here, arbitrary barriers, or like one must know these fundamental things to then be able to be an empathetic,
No.
knowledgeable, skillful practitioner. Really? What are you seeing with your learners, Robbie, that gets you interested or excited about medical school and healthcare in the future?
Okay, like you said, they use quite a lot of technology, like maybe AI. Again, the university is spending a lot of time deciding on AI, like other universities, what students should do, what they cannot do, and how learning can take place in the age of AI. So that's something. and they're good at handling information. Things I'm worried about might be reading a textbook is not really common these days. I don't know how it's in other countries, but
No.
most students just learn when they have to learn. They learn around a problem, but they learn maybe from other resources. Some of them may be good. So I spend quite a lot of time teaching them about what resources they should consult. How do they know a resource is something they should look at, or some resource may not be of good quality because there's a lot of information on the web, not all of it will be of good quality. So that's something, especially in the PBL, I do spend some time telling the students about that. How things have changed, I believe. Maybe they don't. I'm not sure whether students will go to rural areas and some of those things, how many of them will go and what kind of things they practice. Again, I think lots more women, I think just like in other countries. I think the gender has changed because our times, I believe we were about 60% male when I went to medical school. Now I think it must be the other way, 60 to 70% female. So, yeah, quite hardworking students.
Mhm.
Some of them are very focused, some of them are less so, but that's something we expect everywhere.
Mhm.
And usually they work well in a group, at least in a PBL, I found. Some groups might, usually all groups might start working well because I've also been doing PBLs now for quite some time, maybe more than 2 decades.
Mhm.
So again, some of those issues I might be able to tackle. So I think medicine is changing, the demographics, how technology is very much into medicine. And students might have access to information, the one you just told. What should students really know? And what should students be assessed on, when information is so readily available? So that's where I believe faculty might have a difference of opinion. Some of them might say, still insist, those are the fundamentals. So what really they should know is something which I believe we might have to look carefully. Because when there's already so much coming into the curriculum, that again is something, and so many things students have to learn these days. Because so much new concepts, new subjects have come in. So
Mhm.
what? And our time is very limited. Medical school still, we are not really expanded, and we cannot. Maybe it might be challenging. So what students should really know and what they should be assessed on is something I feel we may need to look carefully. Again, as faculty, I believe we have different people with different sub opinions.
Yeah. Yeah, gosh, you really inspired so much thought here. When you first said reminded us that people don't read textbooks, I immediately recalled my friend Dr. David Newsom, who wrote the textbook on neuroradiology. And we just had him as one of our speakers in our faculty leadership collaborative mid-career boot camp. And he mentioned, when I first wrote the first edition of neuroradiology, and I'm going to make up numbers here, but he said something like, 12,000 copies were sold. And now they're in the seventh edition. I don't know what it is. It's all many editions later, and they've sold like 130 copies. So clearly we don't have fewer neuroradiology people and experts. It's just that interest or the demand for textbooks, we have to rethink, where is knowledge resting and how do we pivot our curriculum, the way we interact with learners, the way we interact with patients, knowing that there's infinite knowledge on the web. And then that led me down the hole of what you were saying earlier. Part of your curriculum, you mentioned that you teach learners how to critically read the literature. And that lit something up that we always have to be critical thinkers no matter what information that is thrown at us or available to us on the web. There's that moment, if we're good, we're pausing to say, is that right? Is it just? Is it true? Is it honest? Is it kind? Is it necessary? So this is great. And I will leave the parting comment to you, Dr. Ravi Shankar.
So FAIMER, I think, has been a good journey. interesting. And because the time they brought it in, I joined in 2007. Many of those concepts were new, like, the interaction, adult learning. Many of those things we could apply. When educational research, some of the tools and techniques they brought in. And again, I believe the humanities has been quite interesting over the last, say, nearly 2 decades now. So it started with FAIMER. Initially, there were some struggles, but after that, been quite interesting. In multiple areas, I found students always open up quite well since we used it in multiple settings, multiple schools and countries. So I enjoyed being talking to you and getting to share ideas.
Well, thank you, Robbie, especially since you're talking to me. It's 7:30 my time, but it was 8:30 p.m. your time. So thank you for sharing your evening with us. And friends, if you want to learn more about FAIMER, the Foundation for Advancement of International Medical Education and Research, it's FAIMER.org, FAIMER.org. And we'll put links to our other FAIMER guests who've been on the podcast in Ravi's episode. But Dr. Shankar, thank you so much for being with us, and I hope you come on back.
Thank you so much for having me.
Thanks for tuning in to the Faculty Factory podcast. We are a faculty development community sharing tools to build academic leaders in healthcare. Maybe you want to be interviewed on the podcast? Please visit facultyfactory.org/contact and send me a message there. The Faculty Factory podcast and website is sponsored by the Office of Faculty Affairs at the University of Texas Medical Branch in Galveston, Texas.